Good afternoon. Hi. Maybe turn it up a little bit. There we go. Hi, TJ Milling here from Austin and Houston. Here today to do the symposium on DOACs and reversal of DOACs and intracranial hemorrhage, a topic near and dear to all of our hearts for a couple of decades now, as we went from the warfarin era into the DOACs, and while they tend to be associated with a quite a bit lower rate of intracranial hemorrhage, we still have to do something when it does happen, right? So first I have to read these sort of CME things, because I want you all to get your CME hours. I know how important those are. So let's just go through this. It's addressing challenges, best practices for DOAC reversal and intracranial hemorrhage. The other faculty members here today are Anne Alexandrov. She's a PhD and professor of nursing and neurology at the University of Tennessee Health Science Center in Memphis. Paul Dobesh, PharmD, professor of the College of Pharmacy at the University of Nebraska Medical Center, Omaha, Nebraska. Josh Goldstein, who I've worked with for a long time on this very question, anticoagulant reversal, is a professor of emergency medicine at Harvard Medical School and the chair of emergency medicine research at Mass General, Boston, Massachusetts. And I'm TJ Milling, associate professor at the Dell Medical School in Austin and a professor at the Fertitta Medical School at the University of Houston. So please complete the pre-symposium questionnaires at this time. I think you've already been asked to do that. You want to crank it up a little bit? Is that better? Okay, good. I'd like to thank Vox Media for sponsoring this program and AstraZeneca for providing a grant, unrestricted educational grant. To receive credits, please complete the evaluation form on your seats and return it to the staff at the conclusion of the symposium. There's a slide handout for everything we're going to talk about. Presentations may be viewed later on the NCS On Demand Online Learning Center. Question cards, we love questions, are at your seats there. Fill them out and they'll be handed up here to the panel so we can answer them, hopefully. Future programming can be seen at CMEPlanet on Twitter and other social media. Put your phones on silent. Okay, I think we've done all the housekeeping. Nice to be with you this afternoon. I think we'll start if you can advance the slides. So managing major bleeding on DOACs, just an overview of the fundamentals. This is TJ Milling from the University of Houston, representing the University of Houston. Next slide. These are my conflicts of interest: AstraZeneca, CSL Behring, and Octapharma. Next slide. So the Three Rivers model of coagulation, actually not the best model, but it is simplistic and easy to follow, right? So you have 12, 11, 9, 8, 10 in the intrinsic pathway, factor 7 meeting at the prothrombinase complex of 10A and 5A, which produces thrombin, prothrombin to thrombin, 2 to 2A. So the two DOACs, the better mousetrap that pharma built in response to warfarin, which was kind of a dirty drug, right? It's kind of a shotgun approach to anticoagulation, affecting factors 2, 7, 9, and 10, protein CNS. Well, if we could target individual factors, maybe we could make an anticoagulant that was still effective at preventing thrombotic events, but caused less bleeding. And of course, those major randomized trials in the 2010s and before bore that out. Then we ended up with factor 10As, which is, of course, the vast majority, 6 or 7 million Americans taking factor 10A inhibitors right now, and the thrombin inhibitors, the direct thrombin inhibitors, which are less common here but still used in Europe quite a bit. The dabigatran is the only one on the market. So rivaroxaban, apixaban, edoxaban, and betrixaban all bind directly to factor 10 and inhibit that part of the cascade, while dabigatran binds to thrombin, factor 2A. Next slide. So what is major bleeding? Of course, those of us who take care of patients in the clinical arena, right, you can try to apply these things, but you're not going to know if there's a hemoglobin drop when you just have one hemoglobin to go by. And it's more of a question of how the patient looks. Do they have clinical signs of shock? Are they sweaty? Are they blue? Is their pressure really low? But these scales, which were developed really to measure major bleeding in anticoagulant trials, right? Post hoc, did they have a major bleeding episode when we have all the data, unlike in the ER or in the ICU where the patient is cratering in front of you. But they're a reasonable approach to deciding who might need intervention when you have the data with an anticoagulant reversal agent. So the ISTH is probably the most broadly used and most simple, really. 2-gram hemoglobin drops or bleeding into a critical organ. But I do think BARC probably captures, by BARC 3A, Bleeding Academic Research Consortium, 3A and 3B probably represent the truly major hemorrhage patients when it comes to DOACs that need immediate reversal, but with the 3 to 5 gram drops in hemoglobin. Next slide. So use your clinical judgment, again, based on vital signs and how the patient looks, on who might need reversal. But always, of course, first you're going to monitor your ABCs, airway and breathing, and then in particular circulation. When it comes to exsanguination, you're going to want to treat shock. We're talking primarily about intracranial hemorrhage, which is small volume, big consequences, but small volumes. But airway management can be particularly important in ICH. And of course, knowing exactly what medications the patients are on. Next slide. So the 4 R's. It's important that, so we don't generally, in most clinical environments, have point-of-care testing for anti-10A levels, which primarily what we're dealing with in the US. To know exactly whether a patient has a true anticoagulant level on board. So we kind of use time as a surrogate. It's not perfect, and that was borne out in one of the Indexinet trials. About a third of the people who, by time, should have been anticoagulated actually weren't. But barring the development of, which they are developing, but broad availability of point-of-care anti-10A tests, we'll probably use time for at least the next few years. We need to know about comorbidities and medications. Where is the patient bleeding? Obviously, the highest consequence compartment to bleed into is your brain. So rarely do I see factor 10A bleeds where it's a recent enough ingestion to use charcoal. It's actually more effective with the direct thrombin inhibitors like dabigatran, but it's pretty unusual for me to be able to do that. If they took it in the last hour or two, it's a reasonable thing to do. Of course, if there's a way to source control bleeding, less common in ICH, you can get your interventional radiologist on board or endoscopist, GI. More challenging than it sounds. And then, of course, we're using the appropriate reversal agent for whatever anticoagulant you're using, which would be PCC for warfarin-related hemorrhage, idarucizumab for dabigatran-associated hemorrhage, and Dexanet for factor 10A, particularly rivaroxaban, apixaban-associated hemorrhage. Next slide. So measuring at the bedside. Obviously, PT is wonderful for warfarin, but it really isn't as useful for the factor 10A inhibitors. It can be useful as a qualitative measure for rivaroxaban, but it can really fool you with apixaban. Patient can have a fully anticoagulated with apixaban and still have a normal PT. So be careful. It would be great if you had a calibrated DOAC point-of-care assay, but most people don't. You can use a heparin assay, like a Lovenox assay, to get a sense. I mean, if you're at 0.2, you probably aren't anticoagulated. Your factor 10A is not inhibited. If you're at 0.4, there's some inhibition. Obviously, if you're at 1 or above, you're truly fully anticoagulated. Oh, okay. I didn't know I had a clicker. All right. For DTIs, which we don't deal with that much in the US, but PTT can be the qualitative measure. If you can get an eccrine clotting time or a dilute thrombin time, those are a little more accurate. You're probably only going to have a PT-PTT, though, and you'll probably use time as a surrogate for whether they have a true anticoagulation on board or not. And DOAC half-lives generally range from about 8 to 12 hours. Time matters, right? So in the hematoma expansion literature, particularly in anticoagulated hematomas, intracranial hematomas, It happens early. It happens in the first couple hours. So you really, if you've ever watched one of those patients evolve from a GCS of 3 or 4 to, I mean, from a 14, 15 down to a 3 or 4, it's really dramatic. Once hematoma volume expansion starts happening, it's sort of too late. Cat's out of the bag. So you want to do all you can to preempt that expansion and save the brain. So you should move quickly. And if a patient is suspected of having an anticoagulate-associated hemorrhage, you need to get the right reversal agent on board as soon as possible. All right. Thank you very much. And I believe, Anne, you're up next. Oh, am I looking at the wrong thing? Oh, sorry, Josh. It's you.
I'll be happy to do. And are we going to do questions afterward, or are we going to do them in between each talk?
I think they're after.
They're afterwards.
Yeah.
Perfect. All right. Great. Thank you. First, can everybody in the back hear me okay? Great. So I'll talk next about reversing thrombin inhibition in intracranial hemorrhage. These are my disclosures. I won't talk through them, but you can look them up. They'll be on your handouts. When we talk about thrombin inhibitors, at least in the United States and in most places, the major thrombin inhibitor that your patients would be on is dabigatran. This is a small molecule. It binds to the catalytic site of thrombin. And when you look at the picture, the reason I bring up that it's a small molecule, this will come up in later talks because there's other agents that aren't. It binds to the catalytic site of thrombin, which is factor 2. And so it's blocking the patient's factor 2 from doing its job. And the half-life is about 12 hours, relevant because, as you heard, warfarin's got a super long half-life, and time is not your friend. Here, because the half-life is 12 hours, you can really be thinking about, boy, if the patient's last dose was only, was a day or 2 days ago, it's really cycled through maybe a couple half-lives or a few half-lives. Clearance is 80% renal. When we think about reversing this, there's only one agent that's approved for this purpose, and that it's specific for this purpose, and it's called idarucizumab. For those of you who look at this word and you feel like you don't know how to pronounce it, there is a way to pronounce it. Idarucizumab. And you can think of MAB at the end because a monoclonal antibody. That's why MAB got thrown at the end, right? So it's a monoclonal antibody, so it's got MAB in the name. You can try to remember it. Somebody highlighted. It's got it's dabigatran, so it's got the DA in there if you're trying to remember the thing. But also, frankly, if you ask your friendly neighborhood pharmacist, how many pharmacists do we have in here, by the way? A lot of pharmacists. Great. What I tell my ER residents is ask the pharmacist, because you're not going to remember it. I hope they remember it. I hope you all remember it. But if not, I hope the pharmacists remember it, because I'm counting on you. This is a humanized monoclonal antibody. Idarucizumab has 350 times the affinity for dabigatran compared to thrombin. So what's happening here is that the patient has thrombin, factor 2. It's got dabigatran, which is binding it. But now you've infused this monoclonal antibody that binds dabigatran, pulls it off the patient's own thrombin, releasing the patient's thrombin to go and do its job. Dosing is 2.5 gram IV injections, 15 minutes apart. So it's like, I think of it as a bolus. It's technically 2 boluses, but it functions like as a bolus. The reverse AD clinical trial was a single-arm study. We don't have, unfortunately, a placebo-controlled trial of a reversal agent for thrombin inhibitors. We just have a single-arm trial. Of this trial, 33% of the patients enrolled had intracranial hemorrhage. 13% had subdural hematomas, 9% subarachnoid hemorrhage, and 18% ICH, intraparenchymal hemorrhage. What you're looking at here, the y-axis is the concentration of unbound dabigatran. The x-axis is time. So what you are seeing at time 0, how much dabigatran is in the system that's not bound. And then what you'd like, if you have a reversal agent, it's pulling dabigatran out of the circulation, right? You want to undabigatranize the patient so that their factor 2 can go back to doing its job and helping stop the bleeding. So if you look here, the IV infusion of idarucizumab immediately reduces unbound dabigatran levels to near 0. And if you look at 30 minutes, 1 hour, 2 hours, 4 hours, you're really seeing effectively 0 level. There's a small rebound that happens that looks like it's out at 24 hours. So you think maybe a little bit of a rebound for some folks at 12 hours, a few at 24 hours. But even at 24 hours, most people, still, you've really undabigatranized them. There are other laboratory parameters, and what I'll highlight here is really 2 dilute thrombin time and Ikarin clotting time. These are other laboratory tests that you can try to use to see if you've successfully unanticoagulated the patient, right? Sort of recoagulated the patient. Again, and you look at the pattern of them. Again, the y-axis, higher on the y-axis you are, the more sort of dabigatran function you have. Bottom of the y-axis is when there's no dabigatran function, which is what we want when you have intracranial hemorrhage. And if you look at as the x-axis, as time marches on, that really after that single IV infusion, you're down at the bottom. I'm going to highlight renal insufficiency. So this drug is, idarucizumab, is renally metabolized. So you can wonder what's the impact of people with renal insufficiency. We certainly have many with, oh, do you need me to say something here for folks? No. Okay, great. Oh, questions, fantastic. Please write questions down because we would love to answer them. So if you look at the graph at the top left of this screen is the people with the most severe renal insufficiency. And so if you look at this graph on the top left, even with severe renal insufficiency, on the x-axis, right after the infusion, you've effectively undabigatranized the patient, but there's a bounce up, a little bit out at 12 hours and more out at 24 hours. So the patients who have renal insufficiency, what you should worry about is whether they're still anticoagulated out at 12, 24 hours after you've given them this reversal agent. Because of course the problem is, it's not just your reversal agent, it's the dabigatran itself, right? With renal insufficiency, they're just not clearing a lot of the agents that they're on. But in moderate or mild renal insufficiency or with normal renal function, you can really see this is minimal. Even out at 24 hours, there's minimal bounce up of dabigatran function. So I've given you a bunch of laboratory parameters. You're probably wondering, what's the clinical impact, right? If you have somebody on dabigatran and you give them a reversal agent, this specific reversal agent, am I stopping them from bleeding? Are they bleeding less than they would have if I hadn't infused this agent? So what we'd love is some kind of measure serial hematoma volumes to look for hematoma expansion. Even better, a clinical outcome, right? Clinical outcomes, as we all know, are super messy, so it's a lot of hard for a lot of these trials to use clinical endpoints. A lot of them use, like, are they still bleeding as the clinical endpoint, which frankly is in a lot of studies of hemostatic agents, trauma, other things, right? If you want the patient to stop bleeding, usually the outcome of those trials is, did the patient stop bleeding? In this study, the one done for idarucizumab, they could not assess intracranial hemorrhage expansion because serial head CTs were not mandated as part of the trial, so they didn't have that data point. The best data we have, unfortunately, from that study is the non-ICH patients, where there was some way to visualize whether they're still bleeding. For those patients, about 68% had bleeding cessation within 24 hours. The mean time to hemostasis was 2.5 hours. We do have clinical endpoints, 16% mortality among the ICH patients. This was a selected patient pool for a clinical trial, and we don't have a control group to compare. And we do have a 90-day incidence of thromboembolic events of 6.8%. There was, last year, published a meta-analysis of studies of idarucizumab, putting them all together, looking at how many people have good hemostatic effectiveness using the ISTH criteria that you just heard about from Dr. Milling. And overall, this looks like about 77% hemostatic efficacy with this agent. So I'll conclude here. For dabigatran reversal, the only specific agent we have is idarucizumab. It is effectively used as an antidote. It binds specifically to dabigatran. This agent clearly reverses the anticoagulant effect as measured by laboratory tests. We don't yet know for sure whether any alternative agent or any other approach that you might use would offer a different clinical hemostatic efficacy or safety, because the only prospective trial was done with this agent. There are guidelines for dabigatran reversal. The American College of Cardiology guidelines recommend, the second one on the left is for direct thrombin inhibitor, DTI, which is dabigatran. They recommend administering idarucizumab. If that's not available, to consider PCCs. The American Heart Association, American Stroke Association guidelines also recommend reversing dabigatran with idarucizumab if available, a 4-factor PCC if not. There's a variety of other groups that have published expert guidelines on severe bleeding in patients anticoagulated. All effectively recommend idarucizumab as the specific agent. This is the European Society as well. And I will stop there and look forward to you writing down your questions. Would love to answer them afterwards. Thank you all very much.
Thanks, Josh. That was good. So I'm going to talk, and remember the single cohort trial design that you just saw for the reverse AD study for dabigatran reversal. Now we're going to talk about factor Xa inhibitors and the evidence base behind andexanet alpha. As soon as it shows, there we go. Oop. Yeah. So I need the other slides that are with a red background, if you can get to them. But I'll just talk in general. So dabigatran reversal, the reverse AD trial took off and was completed about a year before the ANNEXA-4, which was the first single cohort trial of andexanet. Here we go. And they were similar, right? Except possibly more clinical outcomes on the andexanet side. But I'm curious, how many people have idarucizumab on your formulary? Just a show of hands. A lot of hands, right? How many people have andexanet on your formulary? Less hands, but okay, more than I would have expected, because I've noticed that the adoption of one was quite a bit lower than the other, and there's some irony in that, but we will get into that in a little bit. So reversing inhibition. So I remember meeting Genmin Liu, who was the Portola, which was bought by Alexion, which was bought by AstraZeneca, which now owns this molecule. But the very first time he explained to me how this thing was developed, I'm like, that's pretty smart. So you took essentially native Xa, and it's a serine protease, right? And you take the serine out and you put an alanine in there, so it no longer cuts prothrombin and thrombin. But then you've got a problem at the other end of the molecule that it might bind with factor V, if you bind up all your factor V, it's going to become an anticoagulant. So you want this inert thing. So you chop off the protease on one end, chop off the GLA domain on the other, and you have this very inert thing that still binds the inhibitor, but doesn't interact with the clotting cascade, at least not directly. There's a TFPI interaction that, well, we'll get into in a minute. But this is a pretty clever decoy molecule. That's what andexanet is. It binds up the inhibitor so that your native factor X can then function in the clotting cascade and clot when you need a clot, when we need to turn the anticoagulant off. And ANNEXA-4 was the single cohort trial, and you can see it's very effective. It drops the anti-10A levels drop like a stone. The real question with it is, as the science has evolved, is like, well, is that meaningful, just dropping the level? Does it stop the bleeding? Which just kind of gets into what Josh just said. I mean, it's a bleed. It's an anticoagulant reversal agent. It's sort of like almost like a toxicology study where you have an antidote, right? You can turn something off. And then how far do you go into, does it have to improve clinical outcomes? And as opposed to a study of, say, a hemostatic agent like Novo-7, which had the FAST trial, where it was non-anticoagulated patients in ICH, and you wanted to show that it improved outcomes. Because you weren't reversing an anticoagulant, you were simply giving this agent and seeing if it reduced hematoma volume expansion. So during this whole period of about a decade, the development of andexanet alpha, we already had PCC on formulary everywhere because it was approved. Actually, Josh and I did the K-Centra trial together that led to its approval for warfarin reversal, right? So why do we think that PCC would work for factor Xa inhibitors? I mean, there is factor X in it, right? It has 2, 7, 9, and 10. But the truth is the amount of factor X in even the high dose of PCC is probably a couple of orders of magnitude below the level of a factor Xa inhibitor. So you're not overwhelming the inhibitor. Maybe, I mean, there's this other idea that you're just overwhelming the whole system with clotting factors and somehow pushing all the reactions toward clotting. Sounds a little bit like wishful thinking to me, but during the period over the development of andexanet, people already had PCC and started using PCC. So it became almost the standard of care while the more specific reversal agent was being developed. Then there's no, other than this trial we're about to talk about, there's no prospective, certainly no randomized evidence for using PCC for reversal of factor Xa inhibitors. So this was the trial, right? It took place over about 4 or 5 years, randomizing, excuse me, randomizing patients to either andexanet or usual care. Immediately people would say, well, why didn't you just make it PCC in the control group? Well, first of all, PCC is not approved. And second, PCC, the term, covers a lot of things, right? There's 3-factor PCC. There's 4-factor PCC. There's activated PCC. And as much as you might think that the way you do it is the way everybody does it, you would be wrong, because there's a fair amount of people who do use activated versus 3-factor around the world when you're doing a global clinical trial. There's no way to get everybody to agree to that. So randomize with usual care. Use what you usually use. And most of that was PCC, and most of that, about 80%, was 4-factor PCC. But it was difficult with a global clinical trial to get everyone to agree if you do exactly the same thing as their usual care. So it was important to capture patients early, because as I said earlier, hematoma expansion happens early. It was important to capture patients who took it in the last 15 hours or so that we could have some sense that they were truly anticoagulated. Even then, though, if you take the 6 hours, because as I mentioned, most hematoma volume expansion happens in the first 2 hours, but you have to be realistic with your sites. How many patients can you actually capture if you say you have to get them in within an hour of their onset? This trial might have taken 20 years instead of 5. But assuming that most of the expansion happened in that first 2 hours, you can see that potentially the difference is bigger, right? So if the expansion already happens and then you randomize, if the cat's out of the bag, an effective agent and an ineffective agent will perform very much the same if the expansion has already happened. That said, potentially the difference between these two agents in terms of efficacy could be even larger if it were given sooner. The primary effective hemostasis composite endpoint tried to capture, and we had lots of conversations about this, both the traditional hemostatic efficacy endpoint, which is in ICH, based on hematoma volume expansion, plus a clinical marker, in this case, the NIH stroke score, a fall of more than 7 points. And of course, whether or not they use rescue therapies, such as additional PCC, Nova-7, whatever kitchen sink the clinicians wanted to throw at them. So you had to meet all three, right? You had to have either good or excellent hematoma expansion numbers, meaning less than 35%. No large change in the NIH stroke score, and no rescue therapy in order to meet the endpoint. It was initially designed as a 900-patient trial. I mean, initially and finally, but there was an interim analysis of 450 patients that was pre-planned, wasn't a surprise, and it met the efficacy endpoint with a p-value of 0.031 in terms of proportion of patients who met those three things in the endpoint. Here's the baseline patient characteristics. There wasn't a big difference in the baseline characteristics, except patients might have been slightly sicker, certainly more pre-existing strokes in the andexanet group. And this is biomarker, right? This is anti-10A levels. This is the purported or hypothesized mechanism of andexanet. It turns off the inhibitor, reduces anti-10A levels, which correlate very tightly with drug levels in factor Xa inhibitors. And you can see that it did, as usual, drop that level like a stone, and PCC had very little effect, and in fact could have just been the usual sort of placebo curve effect on 10A, this anti-10A levels. And here are the pieces of the efficacy endpoint. And you can see, as far as meeting all three, 67% in the andexanet group versus 53% in the PCC or usual care group, and that's a pretty small p-value. So I could totally geek out and get in the weeds on a lot of this stuff, but I'm supposed to keep it to 10 minutes. But we can certainly answer any geeked out questions you want to ask on your cards here in a minute. So the safety side is something worth mentioning, right? Because there were more strokes in the indexinate group. So that piece of the doesn't interact with the clotting cascade, but a caveat was that it affects the FPI, which can create a sort of prothrombotic window after the use of indexinate. We saw that in the healthy normal trials. There was a rise in sort of markers of clotting over a couple hours after administration of indexinate. There weren't any clinical thromboses, but these were obviously non-bleeding patients. We saw a 10% thrombotic event rate in the Annexa-4 cohort trial, but of course we didn't have a comparator group. So this is the first time we had a comparator group, and it does seem to indicate that you pay a little bit of a price in terms of thromboses for an effective agent that actually completely turns off the anticoagulant. And that leads to a number needed to treat of about 9 and a number needed to harm. Treat to produce 1 more case of effective hemostasis, harm to produce 1 additional thrombotic event, and a net clinical benefit is there. And I thought if you compare that basically to TPA, that's pretty close to the trade you get for using TPA in stroke, just as something you're used to that you already use. Certainly we could line the whole slide with lots of numbers needed to treat, number needed to harm. But the point is there is net clinical benefit. And I think I'm a little bit over already. So the guidelines, most of them say use indexinate, and it usually has this little caveat, if available, because I was actually heartened to see so many people raise their hands that they actually have it now, because for a long time that wasn't true. Indexinate is a first line and potentially PCC is a second. I see FFP on this one, but FFP would not be expected to do anything to a DOAC, so don't even bother with that. You might be giving it in a bleeding scenario outside the brain as a volume expander, but it's really going to do nothing in terms of providing enough factor to affect an anticoagulant. Yeah, same, sort of the European guideline. All right, so those are all the guidelines. So now we'll move on to, thanks for that. Dr. Dobish. There you go.
Thank you, everybody. I'll take my slides. There we go. All right, so I've got the privilege of being able to present one of our first cases, and which is head trauma from a DOAC. My disclosures are here. You'll see why this is in a little bit. So my case is JR is a 72-year-old female who was brought to the hospital by EMS with a code stroke. She's watching her grandchildren while her daughter ran a few errands. While she's walking down the hall and talking on the phone, she slips on a toy, falls down the stairs. She remembers coming to a few minutes later. Daughter arrives probably within the next 15 minutes as best that they can figure, and found her still lying on the floor. Upon arrival, she reports a headache, 6 out of 10, nausea but no vomiting. She still seems a little bit on the dazed side. She has some new onset dysarthria, left-sided numbness and weakness. Current vital signs, she's presenting hypertensive at 172/92. She's got a pretty normal heart rate, respiratory rate. She's saturating pretty well on room air. Her current NIH stroke scale score would be 9. GCS score, is also 9, and most of her laboratory information is within normal limits. CT scan showed here, which gives us about a 15 ml hematoma. So one of the things I wanted to share that helps kind of piggyback on some of the decisions from the prospective clinical trials is also there's a lot of observational data that's out there. And observational data can be complementary, not used instead of, but complementary to randomized clinical trials. But there's a lot of limitations. These studies, there's a fair amount of them out there. And I'm going to share with you a study that we did. And one of the things was we could do the same study that everybody else has done, or we could sit back and say, well, how are we going to do this different? How are we going to make something better, more useful? And so one of the limitations to a lot of the data that's out there trying to compare, in my hospital, in my setting, if they get a 4-factor PCC or they get indexinate alpha, is there a difference in outcome? But the problem is most of these studies are fairly small. When we designed our trial, the next largest comparative trial at the time was 109 patients and came to the conclusion it's no difference. I don't know, maybe there's a slight chance of a type 2 error there, right? They don't have the power to make that kind of finding. And most of these are from single center or a single system, right? To get over that, we enrolled 4,395 patients into our observational study, over 354 different hospitals across 42 different states. So I think we conquered that one. There are limited statistical adjustments, right? The biggest thing that plagues the observational data is, does Group A and Group B, are they the same? Now, I will completely concede you can never know that 100%, but you can try to do a pretty good job. And so we actually had a logistic regression analysis that we did in our data, and we were actually so sensitive to this that we actually set up as a sensitivity analysis also a propensity weighted regression, right? So if one model was wrong, maybe the other model was better. So once again, trying to make sure that at least as best we could that groups A and B are the same. It's adjudication from index events, that's almost never available. Variable accepted definitions of hemostasis. I will say that collecting data on hemostasis retrospectively is pretty sketchy. You don't know it's hard enough to figure out when the bleed stopped prospectively, let alone retrospectively, and when did I find it somewhere in a note. And so, and of course there's also inconsistent, like a lot of these studies have no idea when the time from last dose was. Well, if you don't know when they last got their dose, how do you even know you're reversing anything, right? You could just be given something to reverse, the drug's long gone. Hey, we had hemostatic efficacy. Guess what? You probably had it beforehand, okay? So, there's a lot of these differences here. So our study here, which was, like I said, multi-center study, observational, almost 4,400 patients, with patients with major bleeding treated with indexinate alpha or 4-factor PCC. Like I said, a lot of different hospitals across the state. In hospital mortality, we did not look at hemostatic efficacy because at the end of the day, we wanted to look at in-hospital mortality as the outcome. This is our overall population. So you can see the mean age there. Just to note, this mean age is about 12 years younger than it was in an XI, right? You can see fairly decent split between males and females. 85% of our patients, we had time within last dose of 18 hours. Time to treatment, it was about 2.5 hours, very similar. And of course, these are all things that were ended up within our logistic regression model. Overall, most of our bleeds were actually GI in nature, and at the end of the day, while the ICH bleeds are the most devastating, we see twice as many GI bleeds with these drugs than we do intracranial bleeds, but we still had about 1/3 of those. Non-compartmental bleeds that weren't critical compartment bleeds, there were 420 patients there, and we had 80 patients. For some reason, someone didn't tell us what it was. For in-hospital mortality, it was 6% in our patients getting Indexa, which is 10.6% in the patients who got a 4-factor K-Centra basically at the time that this was done. This is all a US database. When you put that into the logistic regression model, that is a statistically significant 50% lower odds of in-hospital mortality. If we look specifically at our ICH subgroup, you can see the breakdown of all the different locations of the bleeds. We also had GCS scores in about 50-ish% of the patients, just wasn't recorded in everybody, which is shown there. The in-hospital mortality, if you got indexinate alpha, was 12.6%. If they got a 4-factor PCC, it was 23.3%. That's the raw data. That's a 10% absolute difference in in-hospital mortality. You put that into the regression model, that is a 45% lower in-hospital mortality is statistically significant. We also then did a sensitivity analysis, including basically the 50% of patients who did have. So we couldn't put a GSS score in our model because it doesn't apply to the GI patients, right? So in the patients where we had a GSS score, we then put it into the model, and as you can see, there's still basically over about a 40% reduction in mortality that is statistically, in-hospital mortality, that's statistically significant. This is the neurocritical care. You probably don't give a crap about GI bleeding, but in case you do, GI mortality was also significantly lower. Which again, you put this into the model, right? And there was actually a statistically significant, very consistent 51% reduction in hospital mortality. And we actually had AIM-65 scores, which is a severity index. And once again, we did the sensitivity analysis, including that sensitivity index, you ended up the same. So like I said, there's a lot of these different studies out there. So another thing I did with Dr. White and a number of colleagues is we conducted a meta-analysis of these observational studies. Now, one of the things, this is the 5th meta-analysis that's out there. What none of the other meta-analyses do is look at risk of bias. This is actually like standard practice when you do a meta-analysis. Okay, you just can't like lump the good and the bad all together and say, hey, look, here it is. That's not really a true picture. And so you look at risk of bias, okay, which is basically the inverse to the quality, right? If your study has a high risk of bias, it's a low quality study, okay? If you have a low risk of bias, it's a pretty high quality study. And so our primary outcome here was to look at these outcomes that I'm about to go through in studies with a low to moderate risk of bias. And we used the Miners score, which is a very well validated score for non-randomized observational studies, okay? You can see the vast majority of the data that's out there has a high risk of bias in them. So if you look at the random effects model, right, even really for all the studies, even the good quality and the lower quality, it still ends up being statistically significant for hemostatic efficacy using Indexa instead of a 4-factor PCC. When you look at in-hospital mortality, right, so the overall effect was not quite statistically significant, but remember, most of that is because of the low-quality studies. That with our primary outcome of the high-quality studies, there is, once again, that magic number of almost 50% lower in-hospital mortality that was statistically significant. And then finally, when you look at 30-day mortality, which there were less studies that actually collected this. Once again, in the overall model, for everybody, good and bad quality was a 50%. Whoops, back up a slide. But if you look at the top, which is the primary outcome, you see that basically 50% lower mortality at 30 days. Thrombotic events, they're not captured very well in retrospective studies, and so you can see these confidence intervals are huge, but at the end of the day, really what you find is that there seems to be this kind of leaning towards more thrombotic events for patients getting Indexa, but not statistically significant from this type of analysis. So if we go back to our case, JR has admitted clovidipine to maintain systolic blood pressure to 140. A lot of people use nifedipine. We use clovidipine at our house. JR is given low-dose Indexa because he was on apixaban. She was on apixaban 5 milligrams twice a day, last dose within 6 hours. The low dose of Indexa is shown there. Elevate the head of the bed, glucose and temperature control, frequent neurologic assessments, all standard care. 12-hour post-CT scan showed no expansion of the hematoma, no further changes in mental status, and so we considered this to be a very successful case of a patient getting Indexant alpha. And I'll take us to the next speaker. Thank you very much.
Okay, so I get to bring us home. And my news is not going to be as pleasant as Paul's, but I think that this is an important message. I also want to say thank you, Paul, for really pointing out the difference between observational work, which is only hypothesis generating, but it can be confirmatory when there's clinical trials that back it up. And the reason I say that is I see lots of times people using observational data as a way to try and come back against the data on Andexanet. And I think that's absolutely wrong, and it's really important that we understand that you can only compare a clinical trial to a clinical trial. And there is no clinical trial of 4-factor PCC or 3-factor PCC, et cetera, with these drugs. So I'm going to talk about a lady named Margaret. She's a very active 73-year-old, as you can see. She's somebody that has a busy, busy life, in fact, in her retirement. And she lives in a somewhat rural community that's kind of on the outskirts of suburbia. So she's recently diagnosed with AFib, and she was prescribed apixaban, which she takes religiously exactly as ordered. She has a history of being extremely compliant with her medical care. And her medical history shows that she has a longstanding history of hypertension. You can see that she had a recent PCP visit, and yet her meds did not change, which is a bit shocking to me. I'm a hemodynamicist, and I happen to be very strict about my patients' blood pressure management, especially if they're on anticoagulation. But nope, she was left the way that she was. She smokes about 10 cigarettes a day. That's the most that she smokes at this point, but she refuses to cut down any further, so that's not helping her pressure either. And she has hypercholesterolemia. So at 11 a.m., she starts complaining of a sudden onset of severe headache with some right-sided weakness, and her husband calls for EMS. And again, she's kind of living out in the boonies a bit, so it takes them about 20 minutes to get there. And they take her to the closest hospital, which is a really small, recently certified primary stroke center. And she arrives there at about 11:50. This is reality for a lot of us. You know, where I work, the outskirts in Tennessee are pretty rural. And this is reality for a lot of patients. So her blood pressure on arrival is through the roof. Now, when you have a blood pressure this high, are you going to go down to 140 systolic? And the answer is, we don't have any data to support that, right? Because the trials that we have really enrolled people that were about 175-ish, 180-ish, not patients like Margaret. But this is very typical of the southeastern United States and what we see. Her GCS is 14. Remember, the GCS is now validated for use in ICH. You can pull up Dr. Wendy Dusenberry's paper on that if you were unaware of that. And her NIH stroke scale score is 6, and her med list is given by her husband. She goes straight to the CT scanner. So here's her CT. And this result comes in at about 12:10. They call telestroke. They get the telestroke physician on the line 10 minutes later. I'd argue that's too long, 10 minutes, right? So start thinking about what are opportunities here for Margaret. And they tell her to bring her down to about 160, which I think is probably reasonable. Again, we're not going to go to 140 given the pressure. And they make a recommendation for andexanet alpha low dose, which she meets criteria for low dose. They tell them to elevate the head of the bed 30 degrees to get her out of there to an NICU at a CSC and to do serial NIH monitoring. So at 12:35, the transfer center starts working on getting her transferred. She also gets a bolus of labetalol while they're waiting to start the nicardipine infusion, which starts shortly after, and you can see their pressure slowly but surely starts coming down. Unfortunately, the pharmacist gets back and says, well, we don't stock andexanet alpha. It's not available at our hospital per the recommendation of our pharmacy. Any of you see this in real life? Because I see this in real life. And it's painful, right? It's only the pharmacist that's saying no. All the doctors have said that they want it, but pharmacy says no. And so they say, go ahead and give her 4-factor PCC. So at 12:45, you can see she's already starting to change neurologically. Transport helicopter tells them, well, you know, we're just finishing another transport, then we got to get fuel. It's reality, right? So they can't get there until about 13:30, 13:45. Her GCS again begins to worsen. They end up intubating her. They start the 4-factor PCC. And helicopter finally gets there and she takes off. But this is what she looks like when she arrives at our hospital. She looks a heck of a lot worse on her CT and clinically. They talk to the family, and the family says, you know, she wouldn't want to live like this. And she dies on hospital day 3. So the questions that I have are, could we do a lot better for this patient? A, I would argue her PCP should have had her blood pressure under control. We have a real problem with PCPs telling patients that their blood pressure is acceptable when it's not, and not knowing how to stack drugs, antihypertensive agents, how to pick the right one as the most effective agent and then add to that. I see patients in clinic all the time that come in on crazy combinations of drugs that I just can't even believe. Could they have had a better outcome? Could they have done things faster? They probably could have done things faster. Tiny little hospital, though, right? And what are you going to do in that tiny little hospital? You're going to do the best that you can with the one ED physician that's probably managing a cardiac arrest and a million other things at the same time, right? But could we have perhaps given her the right drug is the bigger question. And this is probably the question that I think is the most important, because I can tell you that we really were pushing with this with the American Heart, American Stroke Association on our scientific statement that we put out in February of 23, where we said all levels of certified hospitals need to stock all antidotes. Margaret didn't have time to wait to get to the CSC to get andexanet alpha. She didn't have time. If you're calling yourself a stroke center and knowing that we have so many patients out there on factor Xa inhibitor therapy, we need to be responsible and stock the agents that are the most appropriate, right? And then here's the last one. What do you do if you're the doctor in that emergency department and you've got a record that's coming out that says that this was the recommended agent, and yet your pharmacist tells you you can't have it? Do you write in the chart, unfortunately, I can't give this because our pharmacy will not allow the agent in our hospital? Wow. Wow. You wanted to give it, you couldn't give it. They won't let you give it. How do you cover yourself? Margaret's family began to look into this. Like, why wasn't there an antidote? Because the PCP, when they notified him that she had passed, said, but I put her on that drug because there's something that you can reverse it with. So then they asked, why didn't she get the reversal agent? Oh, because we don't have it. But you're a stroke center. Do you see my point? This becomes very litigious for all of us, especially the person writing the orders. How do we handle that situation? So I will stop there, and I'm kind of curious to hear what my colleagues on the podium have to say about this or anything else, and we'll also take your questions. Thanks.
Yeah. Okay, is my mic on? You hear me? Okay, so I just got a question that says that an XI showed a increase in thrombotic risk, but the meta-analysis says it's lower, and so so it's not lower. In the meta-analysis, remember, it's not well collected as it would be in a prospective study, so big difference there. And the point estimate said that there was, there was a higher thrombotic risk. It just didn't, the confidence interval included 1. So it was definitely in that same direction as an XI. It just didn't meet statistical significance, and that was probably based on the poor collection from a observational type study. I do want to just comment, those damn pharmacists. I'm a pharmacist, okay? So I think part of this discussion comes from some of the misunderstanding of what the guidelines are intending. I think there's some misrepresentation here. So I had the privilege to be on as an author on the ACCHA paper, right? Now, if you can take yourself back in time, when this drug first came out, Portola had it. Portola was a very small company. They had very limited, I mean, you don't just make Indexa in a test tube. You have to grow it, all right? And so it takes time, and they had very limited manufacturing ability. I can't remember, I think it's like 50, when the drug first came out, only 50 hospitals had access. That's it, that's all they had, all right? So when the guideline comes down and says if available means can you physically get it in the building? Because at the time, a lot of people couldn't, right? And I will tell you, when we put that in our guideline, we hemmed and hawed because we said there's nothing to support it. We're like, well, we got to give people straws. But many have looked at that and said, oh, if it's not available because I decided it's not available, no. If that's what you're doing, you are not following the guidelines.
You're liable.
Well, you're not following the guidelines the way they were intended, okay? So, right, remember, if you're not using Indexa, right, we've shared a fair amount of, this is the pool, the body of evidence, all right? Fine. Then your body of evidence with 4-factor PCC needs to be just as good, and I haven't seen any of that. It can't be, I'm not using that, so I'm left with this. You have to have a body of data to support that. And it can't be just because it's not the other drug, or it's because what we've done. So yet we've got to make sure that when we're making decisions, that we're making evidence-based decisions and have some understanding of the guidelines, okay? So I think that's where maybe some of this perspective comes from. And I know Dr. Milling talked about this towards the beginning, right? I'll tell you right now, there's no pharmacologic mechanism of action you're going to come up with that actually 4-factor PCCs work. You'd have to give like 300 units per kilo, right? You can't overwhelm. You can't. There's too much rivaroxaban and apixaban in the system. You can't overwhelm it with 4-factor PCCs. There's not enough in it. All right, so just, I think if we can get a better understanding of that, we might get to some better decision making. I'll get off the podium now.
No, well said. I think the point he made, being careful with observational data about thrombotic events, is that people tend to go either home or to a long-term care facility at 1 to 2 weeks. So you'll never get 30-day thrombotic. That's why the thrombotic events in a prospective trial are always higher and more reliable than anything in an observational study.
And adjudicated.
Yeah, and independent adjudication committees, too.
Well, and let me add, too, that there are some data that didn't get published in the Anexa-I paper, that the earlier you start any form of anticoagulant, like, for example, even DVT prophylaxis, that the thrombotic rate comes down and becomes pretty similar in each group.
Yeah, 70% of the patients in Anexa-I got some type of anticoagulation, and those who did, you basically mitigate the entire difference that's there. It goes down to 4.8 and 4.9.
Exactly.
So that while yes, there seems to be some separation there, and there's some discussion of why that is, the key is just if you get some anticoagulation, it really levels that playing field.
Yeah, it's tricky though, right? So there's whole clinical trials on restarting anticoagulation, or in ICH patients. Enrich AF. There was, there's a whole. That's Ashkan Shomanesh and Rustam Salman at Edinburgh have done a body of work on this, and some of it is yet to publish. Certainly, it depends on the type of hemorrhage. I don't want to send people out and say you should re-anticoagulate all these people. We won't get thrombotic events, right? If they have a lobar hemorrhage or if they have CAA, the risk of rebleeding is really high versus a deep hemorrhage. So it's complicated, and I'll leave it at that.
Yeah, I mean, we just don't know what that anticoagulation was yet.
Yeah,
That's
so
the key.
restarting in appropriately risk-stratified patients will reduce your thrombotic event rate, absolutely.
I think the other resistant point that I hear when I talk to people is, oh, well, Anexa-I didn't show a difference in the clinical outcome of the patient. And what I always tell people to pause and think about is, if you were going to run an ICH trial, and I'm talking to the ICH gurus here, would your only intervention be reversing the factor Xa inhibitor? Of course not, right? You would have a trial with all sorts of different things, and that's what our whole Code ICH initiative that Josh and Stefan have really organized is all about. It's the fact that we have to hit this from multiple places, right? Blood pressure lowering, early surgical consultation and intervention, all sorts of things, right? And so Anexa-I was not an ICH treatment trial. You also would have had to have hundreds more patients. If you look at Craig Anderson's work, I mean, my gosh, 7,000 patients in his most recent Interact study? I mean, you would have had to have lots more patients. So that's really not an appropriate argument. This trial was set up for one thing, and that was hemostatic efficacy.
Yeah, I think that's a great point. This is not a stroke trial. It's a reversal trial. And yeah, like people are looking at modified Rankins. They looked at it 30 days. Modified Rankin is not a 30-day outcome. So,
Well, and you could argue 6 months is a better time to
Yeah.
look at an ICH patient, right? So,
All right, sweet.
All right. Any parting questions? I guess we're over time. Thank you so much for coming. We appreciate all your
you.
questions. Enjoyed having you.
Please fill out your forms. And
Yeah,
you
don't
want-
forget,
you know,
yeah, to get your CME.
We want you to get your CME and we want your feedback. Very nice.
well, it's a pleasure meeting you.
It's a pleasure meeting you too. Great to see you.
Yeah, man.
Yeah, I don't know. I wish we'd had more questions. But.
hey.
Just didn't. I had it on my mind, but I just didn't get it. Yeah. Yeah. That's a good idea.
I don't know. My boss will know. I think we beat them in attendance. Something about
No, I know they're standing in the bags.
Yeah, no. This is, thank you. Which shoulder should I not hit?
It doesn't. It's just when I lift it up like this. That's when it hurts. So it's just, yeah.
Not that this is going to make me feel better. Thank you.
Yes, I will get back to you.
I mean, it's a